Okay, so my name is Chelsea Mansell, and this is a presentation which I've made about female cancers and specifically the BRCA gene and its role in female cancers. So let's get started. So I decided to base this on a case of a person that I met. So just a little bit about her history. So she's a 44-year-old female. And in December 2021, she was laying in bed reading her son a bedtime story, and she felt a lump in her left breast. She went to the GP, who referred her onto the breast clinic under a 2-week wait pathway because they also believed that this was an abnormal lump. So a bit more about her history. So she has a past medical history of endometriosis, but other than that, she's been pretty fit and well so far. She lives with her husband and her 12-year-old son. Used to work in an electronic factory, but she's never smoked or drunk. Her maternal aunt had breast cancer in her 60s, and she believes her paternal aunt had some form of cancer, but she doesn't know what type. She didn't really know. So in the breast clinic, she was examined using like a triple assessment, and there was found to be a subtle mass in her left outer breast. She also had an ultrasound which showed there was a left upper outer quadrant 24mm lesion, which they suspected to be a fibroadenoma, and the axilla was normal. Mammography showed there was no abnormality on the right, and on the left there was increased density. So a core biopsy was performed. So the biopsy results showed there was a left breast invasive ductal non-specific type grade 3. So a little bit about grading. There's 3 grades that are used to generally describe breast cancers. Grade 1, they look like normal cells, or very similar to normal cells under the microscope. They aren't differentiated from normal cells, and they usually grow quite slowly. Whereas grade 3, they're quite highly different to normal cells. They look quite abnormal in morphology, and these are cells which usually grow faster, and grade 3 tumours usually indicate a worse prognosis. Her biopsy also showed B5B tumour. So in histology, there's 5 classifications that are used, and they range from B1 to B5. So B1 is a normal tissue, B2 is a benign tissue, and B3 is a lesion of uncertain malignant potential. B4 is a suspicious of malignancy. B5A is not invasive, but it's DCIS or LCIS. And B5B is invasive primary breast carcinomas and rare invasive malignancies. B5C is when it's not possible to say whether it is invasive or in situ. And then we also found out at this point that her breast cancer was ER, HER2, and PR negative. So she had what is known as a triple negative breast cancer. So a bit about triple negative breast cancers. So they make up 10 to 20% of breast cancers. Their risk factors are usually younger aged women, premenopausal, ethnicity, Black and Hispanic is more common, and there's quite a strong genetic link with the BRCA1 gene, and we'll talk about that a bit more, that association a bit more. So triple negative breast cancers do not respond to targeted therapies such as Herceptin or hormone treatments such as tamoxifen. This is because obviously they don't have them hormone receptors or HER2 receptors on them, and therefore they don't respond to things like reducing estrogen levels. They're usually treated with a combination of surgery, chemotherapy, and radiotherapy. Outcomes for triple negative breast cancers are usually worse than the other types of breast cancer that you might have heard of, and they are more likely to recur in the first 5 years after diagnosis. Chemotherapy is usually given neoadjuvant in triple negative breast cancer, as there's shown to be an increased pathological complete response, and there's a paper on that, in stage 2 and 3 triple negative breast cancers, there is an increase in response when you use neoadjuvant chemotherapy. Okay, so the plan for this lady was to give her neoadjuvant chemotherapy, and then subsequently she was to have surgery after the chemotherapy, and to have genetic testing and MRI of the breasts. So MRI is done in especially younger women with triple negative breast cancers, especially because the breasts can be quite fibrous. It's used to identify the lesion more exactly, and to look also in the other breast, see if there's any if it's bilateral or if there's any axillary involvement, and get a clearer image of the tumour. So the MRI confirmed a 24mm breast lesion in the left breast. So she was due to have chemotherapy, which was going to be epirubicin and cyclophosphamide every 3 weeks, followed by 12 weeks paclitaxel and carboplatin, which are all chemotherapy agents. And these are the first systemic agents that are used to treat breast cancer. This was about 6 months worth of chemotherapy, and by this time, hopefully the genetic testing results will have come back. It does take around 6 months for genetic testing results, and that would help to decide the prognosis, the plan with her surgery. So she was eligible to genetic testing, but due to being under 60 with triple negative breast cancer, it is known that there is a genetic link to triple negative breast cancers. They're more likely in those with a genetic mutation. So anyone under 60 with a triple negative breast cancer, and that is widening also now to those with like large triple negative breast cancers, can receive genetic testing regardless of family history. And it does take around 6 months to receive the results at this point. So in June 2022, she was found to be BRCA1, have the BRCA1 mutation. So she can now be considered for risk-reducing breast and ovarian surgery due to this mutation. The family can also be tested, and her brother and father were found to also be positive for having the BRCA1 mutation. And it was decided that when her son turns 18, he could also decide whether he wanted the BRCA testing himself, to find out whether he has the gene also. Just a quick note on genetic testing. So a lot of those with triple negative breast cancers are now receiving genetic testing due to the them being eligible potentially for PARP inhibitors, which are a therapy which can be used in BRCA positive breast cancers, and can be quite effective in treating them, and that's quite common with triple negative breast cancers now. So a quick note on BRCA. BRCA1 and 2 are produce proteins that help when they're functioning normally to repair damaged DNA. They're sometimes called tumor suppressor genes. So here's BRCA1 and BRCA2 on chromosome 17 and chromosome 13. Everyone has 2 inherited copies, one from each parent, and there's a 50% chance of, if the parent has a mutation, the child then inheriting that mutation. And even if someone inherits a harmful variant, they will have a normal copy from the other parent, because 2 embryos which are faulty or have the faulty gene can't produce a healthy embryo, that it wouldn't survive past that conception. So everyone has a normal copy and a mutated copy if they have one, and at some point that normal copy will be lost or changed, causing the cell mutation, and that's called somatic alteration. So the risk of breast and ovarian cancer with BRCA, so in women in the general population, they have around a 13% risk of developing breast cancer during their lives, whereas 55 to 72% of women with BRCA1 variant and 45 to 69% with the BRCA2 variant will develop breast cancer by the time they're 70 to 80. Whereas with ovarian cancer, there's around 1.2% risk in the general population, and that increases 39 to 44% with BRCA1 and 11 to 17% with BRCA2. So you can see there's quite a large increase in risk in those with this genetic with the BRCA1, BRCA2 genes. Other cancers which people may be at risk of, fallopian tube cancers, peritoneal cancers, pancreatic cancers. There's a risk of prostate cancer in men, especially with BRCA2 over BRCA1, and also breast cancer in men as well. So a quick update on our lady that we were speaking about at the beginning. So she had post neoadjuvant chemotherapy, and there was an ultrasound repeat of her breast, which was done, and it showed that there was actually now no visible mass in the breast at all. She also had an MRI scan, which again showed that there was now no lesion that was visible in the left breast at all. Due to her being positive for the BRCA1 mutation, she was still eligible for risk-reducing surgery of the breasts and ovaries, so she decided to have a right mastectomy as well as a left in order to reduce that risk of recurrence of cancer. And she also decided to have a flap reconstruction, which is where they use fat from the stomach, an incision made in the stomach, and some of the fatty tissue from the stomach is put into the breasts in order to reconstruct the breasts. Histology from the surgery showed there was actually no residual cancer after chemotherapy. And she was referred to gynae for risk-reducing ovarian surgery and started radiotherapy to the chest wall. So it sounds like she was going to have a risk-reducing gynecology surgery. So she agreed to having a BSO, so a bilateral salpinge oophorectomy. So she was going to have her ovaries and fallopian tubes removed in April 2023, and they went ahead with that. When they biopsied and looked at the ovaries once they'd been removed, there was an ovary high-grade serous carcinoma of primary tubal origin, and fallopian tube cancers are quite common in those with BRCA mutations, and it was deemed FIGO stage 1C, grade 3. So we'll come on to FIGO staging in a minute. The completion surgery, they didn't, so she'd obviously already had cancer at the point where they were planning on just doing a risk-reducing surgery. So they decided that she required completion surgery in the form of a hysterectomy with removal of the omentum and any disease, followed by chemotherapy, because there was already a cancer there. And then when they examined her on CT, there was no spread elsewhere. So this is a note on FIGO staging. So in general, there are 5 stages. Stage 0, carcinoma in situ. Stage 1 is confined to the organ of origin. Stage 2, there's invasion of surrounding organs or tissues. Stage 3, there's spread to distant nodes or tissue within the pelvis. And stage 4 is when there's distant metastases. So at the minute she's stage 1, so she's confined to the organ of origin. There is ovarian and fallopian tube cancer. So when she went to have her TLH, it was actually abandoned, as when they had a look, there was new nodules noted in the pouch of Douglas, and also a 3 by 2 centimeter bowel nodule, which also required an open, which was now deemed to require an open surgery. So you can see within the time that it took to have this for surgery, there was further spread of the cancer. So the plan now was that she required a staging laparotomy. So she needed a large incision down the midline. She was going to have an abdominal hysterectomy. She also required a pelvic peritonectomy, a mentectomy, and bowel resection due to the presence of cancer in the bowel. And they managed to do an end-to-end anastomosis, so the patient didn't require a stoma. So she had the surgery on the 9th of August 2023, and the new staging was deemed FIGO stage 3B. So if I just go back quickly, you can see that FIGO stage 3B means that for the ovarian cancers, that it means that macroscopic peritoneal metastases beyond the pelvis up to or less than 2 centimeters in greatest dimension, with or without metastases to retroperitoneal lymph nodes. So that's the point. That's the definition of like her cancer at this point. So she was decided that she was for adjuvant chemotherapy, and she required 6 cycles of paclitaxel and carboplatin every 3 weeks to finally put an end to the long journey that she's been on. She's currently on cycle 4 of her chemotherapy when I spoke to her, and yeah, that's all for this presentation. So in summary, we've spoke about breast cancer and BRCA1 in its contribution towards breast and ovarian cancer, and the increased risk that patients are at due to having these genetic mutations. We spoke about some of the management of patients with these mutations, and also spoke about a case study alongside that. Thank you very much for listening. That is everything